In today's video, we're going over evidence-based diagnosis and treatment of hamstring strain injuries. Okay, so why do we care about hamstring strain injuries as a clinician? I think the big one is that they often occur right in the middle of a season. So if an athlete, in the middle of their soccer season, they strain their hamstring, all of a sudden they're not sure when can they get back, if they get back too fast or they go into restrain. And it's your job as a physical therapist to tell them when and to rehab them appropriately so they get back as soon as possible and reduce that re-injury risk. So in today's video, we're going to go over how to diagnose and treat these injuries. Kevin, what are we talking about today?
Dan, I'm excited for this one. It's part two of the hamstring episode we had last podcast. And last episode was kind of a big background, just learning about the different ways to classify hamstring strains, what the risk factors are, and all that good stuff. And then today we're going to go over diagnosis, examination in the clinic, and then how to rehab these things.
I am excited for this one.
So I think of all the things that we kind of see as physical therapists, diagnosing hamstring strains is actually on the easier side of some of the things that we have to try to diagnose. Usually, when the person comes to you, they report a sudden onset of posterior thigh pain, and it's going to be related to activity. So, this isn't something that is brewing over the course of time. We might think that could be more likely a hamstring tendinopathy or something like that. Very often with this, we see a diagnosis which will include sprinting or sometimes like a quick first step. They're going to report a pull in their hamstring, and I think it's usually that simple. Um, Now, when we're looking at them, they might have bruising, they might not. I think more often than not, they will. But just because they don't have bruising, don't think it's not a hamstring strain. I don't think that's needed for the diagnosis. Sometimes, too, depending on the grade, and we'll get into one of the grading systems, we may see a defect. And what this would be is when you're looking at someone's hamstring, you actually see like a divot in the muscle belly. And I think that's often a sign that it's a more severe injury. So we'll talk about that a little bit coming up, but you do want to be on the lookout for that. When they report their pain location, they're going to point to their hamstring. And I think the thing about the hamstring is you can have a muscle strain kind of anywhere in that length of the hamstring. So it could be proximal all the way up by the origin. It could be kind of mid belly, or it could be distal. So I think anywhere on the posterior thigh is fair game for this. They're going to report a reproduction of pain with palpation. When stretching their hamstring, it's probably going to feel pretty crappy, and when they contract their hamstring. So, kind of classic muscle injury symptoms. And then, if we wanted to get a gold standard diagnosis, we would get an MRI because that could tell us the amount of tissue damage. And it's used in one of the grading systems that we'll go over. But that's kind of the background on diagnosis. I think it's fairly straightforward.
Pardon the interruption, but it looks like you're a hamstring guy. Is that true? Do you want to learn about hamstrings? Because I got something I think you're going to enjoy. It's an evidence-based cheat sheet going over hamstring strain injuries. And my promise to you is I'm going to catch you up to date on the latest evidence about hamstring strain injuries under 10 minutes. Staying up to date as a clinician is a pain in the butt, just like a hamstring strain injury. But it doesn't have to be hard because now we have a solution. We go over all the heavy hitters like incidence and prevalence, pathoanatomy, as well as risk factors, the clinical course of hamstring strain injuries, whether or not your patients need surgery, re-injury risk, as well as return to play. Best yet, this cheat sheet is 100% free to download. I'll leave a link in the description where you can check it out and download it right now. Like I said, the goal is to catch you up to date in under 10 minutes. Now, back to your video. Yeah, I agree with you. I just wanted to say, personal anecdote. I've strained my own hamstrings probably 10 or 15 times over the course of my life. Never had any bruising. And I've treated a ton of athletes without any bruising. And then you'll see some that have incredible bruising, but it's not like you need to have that bruising to make the diagnosis.
All right. So, one of the common classification systems that you might see, this is the British Athletics Muscle Injury Classification, or BAMIC. And they have a pretty cool grading system where there's two parts. There's the amount of tissue damage, and then there's the anatomical location. So, the tissue damage, they're going to grade it from a 0 to a 4. A 0 is like you take an MRI and everything looks totally normal. A 1 with an MRI, there's a small tear. And I actually thought this was interesting when I was looking at this. Oftentimes, delayed onset muscle soreness will show up as a 1. So you actually get some like, micro damage of the muscle, explains why people get so sore. So it is somewhere on the spectrum, which is pretty interesting. A 2, you have a moderate tear. A 3 is an extensive tear. And then a 4 is a full thickness tear. And then in terms of anatomical location, an A, the tear is in the myofascial part of the hamstring. B, it's in the musculotendinous junction. And C, it's intratendinous. So you might see something if someone comes in with an MRI, maybe it says like a 3B or a 4C. And then you kind of have an idea of the amount of tissue damage and the location. And in this paper, they were mentioning that when you have damage to the tendon, so a grade C in terms of anatomical location, it could be a more significant recovery. So that's something to keep an eye out on if there is tendon involvement, especially up by the origin where it attaches to the ischial tuberosity. You're going to want to be careful there and make sure there's not like an avulsion or anything like that. I think if you're suspecting that, you'd probably want to refer for an MRI just to be safe. But I thought this was pretty helpful, and you might see this classification with MRIs if patients do come in with that.
Okay. You might be covering this later, but essentially, if you do palpate a big defect and you're concerned that maybe there was that grading of a 4 full thickness tear, probably send it back to the doc right away just to figure out what the heck's going on.
Totally. And just on that point, I remember talking to our boss, Mike, about this before with a patient. And I never really knew this or thought about this, similar to like a distal biceps tendon rupture. But if you do have a rupture of the hamstring muscle, it is something you have to act pretty quickly on, because if they do repair it, you don't want to miss that window where the tissue is really healthy and it would be a successful repair. I think if you wait a long time, you could risk the surgery not being successful, and you kind of miss that window. So I think if you are on the fence about how significant the tear is, and if it's something that might require surgical intervention, just find a good hamstring doctor in your area. I know we have a really good one near us where we work in Waltham, and I've sent patients there, and oftentimes they're appreciative of that. And then they'll just say, I don't think this is a surgical case, feel free to do PT. And then you don't feel so worried about missing that.
Yeah. That's good clinical pearl, though, because if you do have a pretty bad injury and you don't send back to the doctor, there is that ticking time clock, I guess, right? Before you can't do the surgery anymore. So I thought that was good.
Okay, so just getting into the examination, I just wanted to show hamstring strain injuries are one of the diagnoses that we have clinical practice guidelines for through JOSPT and the APTA. So I wanted to talk about this and just go through and show you their letter grades for certain things that we should be looking at on our examination. So in terms of the physical impairment measures, we have A-level evidence that we should quantify knee flexor strength following a hamstring injury using a handheld dynamometer or an isokinetic dynamometer. So we do want to get a lens into this person's strength. And I think it's pretty interesting that a lot of times you'll see these people being tested very shortly after they had an injury. And when I do this, I'll usually just cue the patient. Don't push in anything that feels more than like a 1 or 2 out of 10 pain. It's very hard to restrain your hamstring with these tests. If the person is blowing through a bunch of pain, going max effort, it is possible, but it's more likely to be a recurrence with sporting and sprinting. So it is okay to test these early. And if you're worried about doing it on the first visit, you might as well test the other side. We'll get into what positions to test in, but just think you do want to test this person's strength. And then the second one here with A-level evidence is that we want to measure the hamstring length. And the way that's recommended to do this, according to the clinical practice guidelines, are measuring the amount of knee flexion with the hip at 90 degrees of knee flexion. Or sorry, the hip at 90 degrees of hip flexion. So you flex the hip up to 90, picture the knees bent at 90 degrees, and then you're kicking your knees straight. And you're measuring how straight the knee is. So you could picture someone who's hypermobile, their hamstrings stretching very well, they're not having any pain. Maybe their knee gets to about 0 degrees, it gets totally straight. But someone with a hamstring strain injury, you might see, 70 degrees of knee flexion, 60 degrees of knee flexion. And that's often very different than the other side. So that's something you want to quantify as well. We have C-level evidence that tenderness to palpation is something to look at, as well as the proximity of pain to the ischial tuberosity. And this might be helpful in predicting return to sport. We would think that the longer length of pain and the closer it is to the ischial tuberosity, the more significant this might be, and it might take longer to return to sport. So that's something that you'd want to look for as well. That probably is a little more significant than a distal or kind of mid-belly hamstring strain. So you do want to be on the lookout for that. And then not a ton of evidence, but F grade evidence here that we want to assess for trunk and pelvic posture during functional movements. So if you watch someone lunge or squat, or even if they're in the phase where they could do a little light jogging, kind of want to look at their angle of their pelvis. I think there is some research to support that greater anterior pelvic tilting with some of these movements may place more demand on the hamstring. So something to look at, maybe not as a top priority as the other two that I mentioned above, but something to consider.
Yeah. And I'll just say that I'm going to make a video for examination of hamstring strain injuries. So if some of this stuff moving forward doesn't make a lot of sense, you want to see it visually, we're going to give you a video. So don't worry about it too much. And then you can check that out once I have it up for you.
Continuing with the examination, so for activity limitation and participation restriction, we have B-level evidence that we should include objective measures of the patient's ability to walk, run, and sprint, and document those changes over time. So kind of looking at how they do early on and then how they're progressing through rehab, making sure that they're progressing well with those things. And then in terms of an outcome measure, there is a outcome measure for hamstring injuries. It's called the Functional Assessment Scale for Acute Hamstring Injuries. And that's given a B level of evidence as something that we should give the patient probably on the first visit. And then, as we're assessing progress over time. So, look out for that. And that's something you should use. So just a summary of those things for examination. So when someone comes in the clinic, starting off with a good subjective, everything that we were talking about earlier, how did the injury occur? What was the mechanism? It should be related to some type of activity, usually some type of sprinting or cutting activity. It's not something that's progressing slowly over time that they just noticed randomly one day. This is something that is a pretty clear mechanism of injury. We want to make sure that we're reproducing their pain with a hamstring contraction or lengthening. We're going to assess for bruising and a muscle defect. If it is very close to the ischial tuberosity and we're concerned of an avulsion, we do want to send to a doc to get it looked at. Or if we're concerned that they had a complete muscle tear, and like Dan and I were saying, this is something that may need surgical intervention sooner rather than later, we want to be confident in referring them. The muscle strength, we do want to assess. One that you'll see often in the research, and as Dan said, he'll make really good videos for these, is a supine 90-90. So that's hip flex to 90, knee flex to 90. This is called an outer range strength test. You're going to do a dynamometer test in that position. You can also test prone with the knee flex to 30 degrees. This is called mid range. And then prone with the knee flex to 90 degrees is called inner range. So those are the three positions you'll see often. Other ones I've seen is even supine with the hip and knee at 0 degrees of flexion, and then you're testing with a fully straight knee. But those three are kind of the big ones, especially the outer range one is the one you'll see cited most often in the research that we'll talk about a little bit down the road here too. And then I think it makes sense to assess the entire kinetic chain. So if the person is capable, you want to watch them walk, maybe do some squats, some lunges, some single leg squatting, some hinging and balancing, and just assessing what does this person seem capable of doing. I think it gives you an idea of where to start your rehab. And also just if there are any big compensations that might put more demand on the hamstring, something we can look at early and intervene on if needed.
I'm sure Kim's going to talk about this in a minute. And he just stated this, but when you're watching someone lunge, squat, step up during the evaluation, it's giving you good feedback about what this athlete can actually do. As a clinician, I think we're constantly thinking like, how hard can I push this individual? Well, you start to get an idea of that once they come through the door and you start testing these functional movements. The other piece is that once you get in a rehab program, obviously we're going to focus on the hamstring, but it's probably good to tell the athlete they can still squat, they can still lunge, they can do all the activities they're currently doing. Let's say they are doing some sort of strength and conditioning program. We would love for them to be able to maintain that as much as possible. You're starting to get some information in that initial examination to see whether or not that's reasonable for the athlete.
All right, so getting into rehabilitation. So, what do we do with these people? Obviously, we want to tailor our rehab, as Dan was just saying, to the person coming in. I think oftentimes there's a lot we can still do from a strength and conditioning standpoint. It's not usually the case that we have to stop all lower body training, and we actually want to. It was surprising to me when I started seeing more of these hamstring strain injuries and looking at their research, is how much you can do with them early on, especially loading their hamstring. You'd think you'd be very, very cautious and it would be a very slow progression, but it's not. These people get back very quickly. That might be part of the problem with why we see so much high rates of restrain injuries. But I think if we're going through a good rehab program, we could still get people back fairly quickly and not be afraid to load them early. And hopefully, with all our testing, reduce the risk of restraining. So I think an important point on that is don't wait for pain to subside before beginning an exercise program. You'll see this very often in the research is that they'll use the pain monitoring model. So if you have the patient working into a 3 or 4 out of 10 pain, that's probably okay. With most of our strength and conditioning exercises, we're not putting the hamstring through too much strain where we could cause a restrain injury. Again, those are higher speed movements where we tend to be playing with fire, I guess. So the patient has to really be ready for those movements, but we can start some pretty hard things pretty early on. So this was a pretty good study in 2020 by Jack Hickey and colleagues. And that's a name you'll see quite a bit in the hamstring research. So if you do want to look up some of his papers, I think he has a lot of good stuff out there. And a little bit of background about this study is it was a cohort study with 42 men between the ages of, average age 26 plus or minus 5 years. They did 2 rehab sessions per week until they returned to sport. Strength testing was performed prior to each rehab session. And high intensity eccentric lengthening exercises were given, and these were via Nordics or single leg hamstring sliders. And they were introduced as soon as the person could do a bilateral hamstring slider through full eccentric range of motion. So they had the patient start with that. Honestly, like the first week, they were doing eccentric hamstring sliders with double leg. And a lot of times, I think it seems pretty scary, but you can just play around with the range of motion. You don't have to go all the way from 90 degrees of knee flexion to 0. Just as they get comfortable, you extend that range of motion. And once they could tolerate that, and tolerating it was completing 3 sets of 10 with less than 2 or 3 out of 10 pain. So I think a lot of people could probably do that fairly early on. Then they progressed to Nordics and single leg hamstring sliders. So these were introduced early. I'd say, within the first 2 to 8 days, actually, which is pretty crazy. So that was the finding, is that the high intensity eccentric lengthening exercises were added between 2 and 8 days after the hamstring injury, despite 35 out of 42 of the patients having pain during the isometric test in the same position prior to initiating this. So, they're coming in and they're testing their strength each session in that outer range, mid range, and inner range that we were talking about. And they might have had pain on the test, and they might have had some pain with the bilateral eccentric hamstring sliders, but they were still able to progress to these exercises, which I thought was pretty interesting. So, we can push these patients pretty early. And then their pain resolution on the strength test wasn't until 9 to 13 days after the injury. So, we don't have to wait for pain to be gone before beginning our eccentric strengthening program. So I think this study showed that pretty good, and just, make sure you're doing that and don't feel bad about doing it.
So I just made a video about Hickey's progression. What I will say is that this study really changed the way I think about rehabbing these folks, because it is pretty dang scary. Your athlete comes through the door. Sometimes they're limping, right? You're afraid to push them very much. You think it's going to aggravate it more, right? And his study really showed that we don't have to be too fearful of the exercise that we choose. And like Kevin said, it was basically if the athlete, and I think in the study, they came in like 4 to 7 days after the initial injury. If they could handle like Nordics when they came in, they would give them Nordics. And I just was kind of looking through the study to see if there was an exact number that Hickey used to figure out what was okay and what wasn't. I couldn't find it. I think he used the word tolerable. If it felt tolerable to the athlete and they can go through a full range of motion, then it was acceptable. And in future interviews, I think he said up to like a 5 out of 10 was acceptable, which is quite a bit of pain, right? And two more things. The other thing that was interesting about the study is that they use those same pain parameters when they got athletes back to running. So once they started that return to run program, they're actually allowed to run through some pain as well, which is another thing I think that clinicians sometimes aren't sure of. They're like, well, for our rehab protocols for a knee, we don't want to have any pain during plyometrics. What about during a hamstring strain? Well, at least in this study, they were running through some pain and that was fine. It didn't influence their return to sport rate. So it's not like we hurt them by trying to push them a little bit faster. And I think in this study, they actually had better strength and they had increased fascicle length. So if you push these people faster, they're probably going to get a little bit better, a little bit more quickly, regain that strength, and maybe reduce that re-injury rate at some point in the future because you're increasing the fascicle length. And the other thing I thought was really interesting, and Jack has kind of addressed this in some of his interviews, but he was only doing exercises twice a week, which is a little crazy to me because when I have a hamstring patient come in, my bias is to give them exercise every day. Sometimes multiple times a day, I'll give them some easy stuff, and then maybe the harder stuff I'm doing less frequently. But yeah, they only did exercises twice a week, which I thought was kind of crazy. But, just a little anecdote that was a little different than what I thought, you should be doing from hamstring. But yeah, he's kind of been on record saying that he just believes that people don't need to push the exercises that frequently. So just kind of interesting. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
Yeah, I'm with you. I like to give people things every day, but just the intensity might vary. So maybe it's those hard eccentrics every few days, but there's something they can do daily.
Yeah.
So I think this is actually this is the paper you were talking about. So this is a 2022 paper by Hickey as well. It's called Pain Free versus Pain Threshold Rehab Following Acute Hamstring Strain Injuries, a randomized controlled trial. In this study, there were two groups. One group was doing their rehab and they had to be pain free. They couldn't have any pain. The other group could work into the pain threshold. Like Dan said, I think it was 4 out of 10, but it was what was tolerable to the patient, right? So and that can vary quite a bit patient to patient. The return to play for the pain-free group was 15 days, and the return to play for the threshold group was 17 days. As Dan said, the isometric knee flexion was 15% better in the threshold group. That's pretty crazy because that's only 2 weeks, a little over 2 weeks. They have 15% better strength. That's quite a bit. And then, as Dan said too, this is a small period of time, but they had a significant improvement in their hamstring fascicle length. Now, what was interesting is that there was no difference in re-injuries between group, but I think we had a very small sample size, very small group size. And I think it just shows too how these hamstring strain injuries are very prone to being re-injured. But I think the important take home is that they had better strength, which we know is a predictor of hamstring strain injuries, and then they had better fascicle length, which we know is something that changes after you have injured your hamstring. Your fascicle length becomes smaller, and then we can lengthen it and make it look better after these programs. So and that's working through pain. I think you're getting more work done. So I'd take that group all day, even if there was no difference in re-injuries in this study. I think if we did this study a bunch of times, maybe we'd find something different. That's just my guess.
Yeah. I'm sorry, I didn't really mention to say the exact same thing prior to what you were going to say.
It just drives the point home, so I like it.
Yeah, it does kind of fit my bias. And if you're thinking about like acute to chronic workload ratio, when people have a significant hamstring strain injury, their conditioning is going to go down, their strength is going to go down, everything is going to go down very quickly because they're not able to do very much. And I think the faster we can push them back to higher level activities, the better we can keep their chronic workload, which is probably a good thing, right? And a lot of these athletes, like psychologically, it's very important. They feel like they can actually work out and do things. So if you can push them a little harder and push them into some pain, I think you're probably helping from that acute chronic workload ratio. But psychologically, it feels a little better for the athlete because sometimes they're really down in the dumps and they may have like a really big competition coming up and they're just really concerned they're not going to be able to compete or play. And I think sometimes that's helpful from a psychological perspective.
Okay, so just getting into the rehab a little bit more, I kind of drew the recommendations from these two sources. One is the hamstring strain injury rehab paper in the Journal of Athletic Training in 2022, again by Jack Hickey, and then the Aspetar hamstring protocol. I think Aspetar has a lot of really good resources, and their hamstring protocol is like a 80-page PDF. So I think it's pretty good. It's a good resource to look at, and I kind of blended these two for the recommendations that we're going to talk about coming up. So this was taken from that Hickey paper, and I just wanted to include this because I thought it was pretty interesting how they were breaking up the different hamstring exercises. It gives you a framework of how to group these things. So one category of exercise they had was eccentric knee flexion based exercises. The second one was a long hip extensor exercise. And the third was a short hip extensor exercise. So those are kind of the three different categories. For the eccentric knee flexor, they went from a bilateral slider to a unilateral slider and a hamstring Nordic. So that was the phase 2. And then phase 3 was a unilateral slider with load and a Nordic with load. So I think that, kind of a basic progression, but pretty nice. And then the long hip extensor, they did that Askling diver exercise, which is kind of like a RDL, where you're really just lengthening on one leg. The hip extension machine you can utilize, and you're doing a bilateral hip extension machine to 45 degrees of hip flexion. So you could picture that's a long hip extension exercise on the hip extension machine. That will progress to the Askling diver with load. So kind of the single leg RDL with load. The bilateral 45-degree hip extension can progress to unilateral. So you can do that with one leg, and that's pretty challenging for phase 2. And then we can also add a bilateral hamstring bridge. And the way they had this was the patient's on their back with their foot on a box. So they're kind of elevated, going through more hip extension range of motion. For phase 3 of that long hip extensor, they progressed to a Romanian deadlift with load, the 45-degree hip extension with load, and then a unilateral hamstring bridge. And then for the short hip extensor one, they did a bilateral hip thrust. The phase 2, they progressed to a unilateral hip thrust. And then phase 3, they kind of kept the unilateral and bilateral. And for the bilateral, they loaded it really, really heavy. And then the unilateral, they added speed. So I thought those were pretty nice progressions. And their criteria to progress was making it through the prescribed sets and reps with a less than or equal to 4 out of 10 pain. So, they're able to work through pain, and you're kind of hitting all aspects of the hamstring with these different exercises. So I thought that was a interesting way to break that up.
Yeah. Good stuff, Kevin. I like that protocol a lot. One of the things I'm curious if you're going to go through this, but the Askling protocol, where they include exercise that lengthen the hamstring, did improve return to sport speed, I believe. I'm not sure about re-injury rate, but that was kind of a cool study which showed that if you're not including those, you probably should, which I think Hickey's original paper didn't, which is interesting. And this seems to actually include those, which is awesome. The other thing I will say is that I've been surprised by how much folks will be able to tolerate after acute hamstring injury when they work through like a partial range of motion. I think once you add that stretch and you start stretching that strain, it's not really as well tolerated early on anyway. So I think that middle group of exercises that include the lengthening, you might just have to slow down that progression. And then basically the top and the bottom maybe is a little bit faster, right? So I think personal experience just shows that different types of exercises just progress at different rates. So you might be surprised that you can actually do like a Nordic, but they can't actually do a single-legged deadlift, which in your mind is like, whoa, that doesn't make sense. Nordic's way harder, but sometimes that's the case. Maybe just because of the stretch. I'm not really sure, but that's what I've experienced.
Yeah, and one thing I was thinking with that protocol is I think their protocol is a very good kind of generic hamstring strengthening where you're hitting it from all these different ways. So like the knee flexed one and then the short and long hip. I think with our rehab protocols, and this next few slides are kind of the ones I made based on the two together. But I think it really depends on the location of the strain, because I think, you're totally right where if it's pretty proximal, they might do better off with a Nordic early on, which I think is challenging more kind of middle and distal hamstring versus that like diver or single leg RDL. You're challenging a little bit more that the origin near the ischial tuberosity. So I think the location might change the exercises. So just something to think about. So yeah, here's kind of the way I wanted to piece it together to just show you how you could do a full PT session with these principles. And again, it's a combo of that paper and the Aspetar protocol. So Aspetar definitely cites doing some manual therapy. I think that there is a good reason to. I think you can help patients with manual therapy with this. It helps them feel a little bit better. So I do some soft tissue massage, maybe some effleurage to help with swelling if you do see some of that. And then also doing some passive motion. I think you don't want to stretch these people too aggressively early on. But as Dan was saying, one of the papers in the Askling protocol is the extender. And that's when they're laying on their back and their hip and knee are flexed to 90, and then they're kicking their knee straight, and you're stretching the hamstring that way. So that abbreviation at MHFAKE, that stands for max hip flexion active knee extension. I guess that's a little more demanding than like a 90-90 knee extension. This is like you're flexing your hip all the way up and you're supine flexing your hip all the way up and then kicking your knee straight. And that's, I tell patients, let's do this until, a 2 or 3 out of 10 pain at most, but we're trying to desensitize the hamstring. So we're trying to lengthen it, which we know from some of these studies is a really helpful way to rehab as early as we can. And then maybe a little passive range of motion into a straight leg raise, just being mindful of the patient's pain. You're not trying to kill them, but you're trying to do some lengthening. And then in terms of our exercise prescription, again, all performed within pain limits of 4 out of 10 or less. I'll start patients with a bilateral hamstring glute bridge. And, if they can tolerate, say, knees flex to 90, I'll walk their feet out a little bit and just try to place a little more demand on the hamstring. We can usually do some type of squat. So a bilateral squat. And then over the course of this phase, we're just increasing load. So maybe we start with higher reps and then drop the reps and add some more external load, whether that's a goblet squat or even if we have to start with body weight, progressing to barbell, I think is totally fine. And then for direct hamstring work, I will play around with isometrics. So you might have someone supine and then at different angles of knee flexion, you just have them kick into the table or the floor. And I think that works pretty well just so they can feel their hamstring contract and get a little load through the hamstring. I think in line with some of the studies that we were talking about, you can start with this phase with the bilateral eccentric hamstring sliders. So you might progress reps over time in range of motion. The bilateral 45-degree hip extension machine. This is one I didn't really think of until I read the Hickey paper, and I've used it a couple times and I like it. A lot of gyms have this, so it's something the patient could use. And again, in this phase, I would just be progressing their range of motion over time. And then the diver, again, I'm kind of with Dan. I think that the divers like that single leg RDL, you'll see this in the protocols as something you can use early on. Sometimes it's just not that well tolerated, and it's something that will add fairly quickly, but we might not be able to start with it day one. It really depends on the patient. So don't be afraid to try it. But if it's just, it's 5 or 6 out of 10 pain, they're not really loving it, I don't think you have to force it. You can get back to it as soon as you can. And then the active motion, this is one I'll give the patient often to do actively. So the extender, which I was explaining, that supine 90-90, kicking your knee straight. And then we can play around with how flex their hip is to make it easier or harder. And that's one I'll have the patient do daily and often many times during the day if they can, just to work on lengthening and trying to desensitize to that. So I think of that as a pretty good phase one. Most of those exercises in this phase, I think, were body weight only. So we could probably do these every day. But as we progress through rehab and we start using more external load, which we'll talk about, the exercises won't be done as often.
That's good stuff, Kevin. I agree with that. One thing I will say is that for that unilateral diver, the single-legged deadlift, sometimes what I'll do is I'll just shorten that range of motion a lot, right? You may find, I've messed around with this, is that the athlete can tolerate load. They just can't tolerate range of motion. So sometimes early on, I'll have them do a diver and I'll give them some load, but I won't push them through a range of motion because there's a very finite point where the pain just kicks in aggressively. But if they stay above that, it's tolerated pretty well. The other thing I've messed around with too is just doing a bilateral diver or just like a hinge variation, RDL, right? Like a deadlift, right? So I know that sounds kind of silly, but I mean, if it hurts to be on one leg, you can just try two, and that might just be the regression that the patient needs. So I'll try to still continue with some sort of hinge variation if possible, right? So if, full range of motion doesn't work, doesn't mean you don't have to do it that day, right? Although they've got plenty of other exercises that are obviously good. The other thing I will say is I know this is an anecdote. I don't have a study that shows that it's more beneficial than not, but I've been really surprised with someone that has very limited hamstring mobility. Then I just do a little soft tissue work, instrument assisted, like some massage. That tends to clean up their mobility pretty dang quickly. I don't have a paper that says that's going to help them return to sport faster, but one of our return to sport criteria is basically having normal range of motion that doesn't hurt. And I think that actually helps to clean things up a lot as compared to just aggressively stretching them, So just a couple kind of clinical pearls that I've found.
So yeah, just quick criteria. How do we know when to get to phase two? How do we know when to progress these people? I think early on, one of the things that you'd want to see in an Aspetar protocol points to this is we want pain-free ambulation. So if the person is walking around with pain, let's just, pump the brakes a little and take it a little easier with these phase one exercises. But if they're able to do that and then they go through your programming for, I usually like at least 2 sessions in a row or at least 2 days in a row where it's not just they had one good day, but they stack a couple days. They're hitting the prescribed sets and reps. I think it's time to progress. So then that would be my criteria to go to the next phase. And so for phase two, we still have a similar framework. So, we're going to do a little bit of manual therapy as needed still. Like Dan said, stretching is a component of this, but it's not the way I think we're going to primarily get our motion back. I think the soft tissue anecdotally does seem to help these people. Maybe there's some muscle guarding or whatever. We could hypothesize about that, but it is helpful. And I'm still continuing with a little passive motion just to desensitize into stretching, a little lengthening passively. For our exercise prescription, we're still using the pain monitoring model. Our bridge variation is progressing from a double leg bridge to a single leg bridge. And here we can go up in weight. We can go up in repetitions as they get better at it. Our squat variation, we could progress from a bilateral squat to a single leg squat, just working on, a little more deficits on one side versus the other. And then our direct hamstring work, this is where I'll start getting into doing it either every other day or every third day, because I think we're starting to do a little more with the hamstring, and they might need that recovery. So in physical therapy, I'll do some prone hamstring curls with my resistance. So I'll have them go through from 0 up to 90 plus degrees if we can, and just, adjusting my resistance I'm giving them based on how they're doing. If they're going to a gym, I think they can start doing this on their own, and just, starting light with the weight, but progressing as tolerated. We're going to progress the bilateral hamstring slider to a unilateral hamstring slider. The bilateral 45-degree hip extension, we could progress to unilateral. And then the diver exercise, we could start, if we were doing it single leg through partial range of motion, we could progress the range of motion. And then we could also start adding some external load to that. And I usually just cue for these when we're going into the eccentric phase, just to go slowly, because we're trying to get that lengthening. If we're thinking on a tissue level, we might be making some changes to the fascicle. So we want to make sure that we're taking advantage of that. And I still have this person doing the extender exercise. So hugging the knee in, kicking straight as a passive motion exercise, doing that every day. So looking at this, maybe I'd have them do the single leg bridge and the extender range of motion exercise daily. And then the other ones either every other day or every third day, depending on their training age and how well that they feel like they're recovering. Something else I didn't have on here that I'd also have the person do is either a walking program, or maybe we could start some light running, which I think I have on a next slide. Or even if all that doesn't feel great yet, still doing some work on the bike, which I do think they could start phase 1 too. You can really get people on a bike very, very early. And I think that helps, accelerate recovery, and it just helps them get a little work in without stressing the hamstring too much. So that's kind of what we're thinking phase 2.
Good stuff, Kevin. A couple things that I had to add. Hamstring strain injury patients are interesting. A, they're typically young, right? And then B, it's a muscular strain injury, so it tends to heal really fast. So for a lot of these patients, and we're in a cash-based system, right? So maybe a little bit different than a traditional in-network insurance model where maybe you see patients more frequently, 2-3 times a week for everyone. I see most of my patients once a week. I do a lot of like one-time consultations, once a month even. For these patients, I tend to see them more frequently. So sometimes as much as 2-3 times a week. And I think that there's benefit from that because they advance so fast. So let's say that like a patient has a hamstring strain injury on Saturday, you see them on Monday, and you give them an exercise program that reflects how irritable they are. By Friday, they could look entirely different, right? So if you're not seeing them frequently enough, I think you're probably not meeting them where they are. So when we're talking about these phases, usually when you think phases from a physical therapy standpoint, it's like post-op. It's like, all right, post-op phase 1, we got this. And then criteria for advancement, phase 2 is in X amount of months. For these hamstring strain patients, and for most folks with orthopedic issues that aren't surgical in nature, it's like you're meeting them wherever they are. Sometimes they're starting in phase 2, sometimes they're starting in phase 1. And the thing about strains is they advance really fast. So it might be like Monday, phase 1, Wednesday, phase 2, and then maybe on Friday, they're like looking like they're ready for phase 3, particularly with certain exercises. So I think don't be afraid to get them back a little more quickly, and just see them on this spectrum where you're trying to figure out where they are. The other piece, and I know that Kevin's going to talk about this, so I won't go too crazy, is that I'll even look at their running on the first day they come in, because if we're thinking about basically trying to minimize that loss and chronic workload and just keep them conditioned as much as possible, if they can run, particularly if they can jog kind of pain-free day 1, I'm thinking about trying to get them to jog pain-free day 1, right? Or do some like agility drills or whatever it is. I want to try to maintain their program as much as we can and not aggravate them. And we have this information from Hickey now that it's probably okay to work into some pain. So if I can keep them doing things to keep them fit, that's my bias. I'm always going to try to do that, because I think sometimes when we think about this phase approach, which is really important, I'm not trying to knock the phase approach, we forget that things that lie maybe outside of that phase approach are probably still appropriate, right? We don't have to get rid of everything. They can still train the way that they're supposed to.
Hey, pardon the interruption, but if you're liking this content, I think I have something else that you're going to love. It's a free mini course where we go over solving some of the biggest problems that physical therapists are facing today. So what are these problems? Number 1, Failing reimbursement. Medicare reimbursement has dropped 10% over the past 10 years, despite inflation going up 32% in the same time period. Documentation and admin overload. Physical therapists are often spending significant time doing notes and communicating with insurance companies, and this is often unpaid. High productivity quotas. Failing reimbursement rates force physical therapists to see more and more patients. Burnout and poor work-life balance. High productivity demands and extra work drive burnout. Insurance-driven restrictions. Insurance companies often cut patients off before they're ready, like ACL reconstruction patients, or they won't cover insurance for certain populations. Let's say a very athletic individual. They don't care about your athlete getting back to Olympic weightlifting. Debt versus pay and balance. The average student debt after graduation is $153,000, and our salaries are not matching this amount of debt. Lack of public awareness and referral dependence. Patients don't always choose PT first. They don't know our strengths as physical therapists, and they oftentimes will favor other healthcare providers. So how the heck do we solve this? We do this through a 6C process to help you start working towards that career of your dreams. And before we go into that, we got to figure out first, what do physical therapists want? So we want to be incredible clinicians. We want to be respected and valued. We often want to work with a specific population in a specific setting. We want to be able to practice the way we want to be able to practice. And generally, we want higher incomes. Now, given the current state of physical therapy, it makes a lot of sense that folks like you and I are upset. So in this mini course, we go over the 6C framework to get off the hamster wheel. It starts with clarity. What is the ideal patient that you want to work with? Next is connection. How do we become part of their community? Next is captivation. How can you help them with their specific problems? Next is competence. You have to learn how to treat these patients inside and out. Next is building confidence. That comes with time and reps, because perfect practice makes you perfect. And lastly, compensation. You want to get paid what you deserve. And this mini course will start you on your journey there. I help you to transform your career, start doing more of what you love and less of what you hate. This mini course is 100% free, and better yet, if you finish the course and then finish the quiz afterwards, which is nice and short, you can get 3.2 CEUs for physical therapists, physical therapy assistants, and athletic trainers. Again, it's 100% free. I'll leave a link in the description. Go ahead and click on that and download it, and I'll see you inside of the mini course. Now, back to your program.
Yeah, and I think that's totally right. And that's something I'd definitely be in agreement with. I think once they're walking pain-free, we can start this jogging program right away. And you're right, like the phases are, don't think of them as traditional phases that we do in rehab. A lot of the times, like you said, are post-op, and people are in certain phases for weeks or months. They might come into PT ready for phase 2 or phase 3 if they come in a week after their injury. So these things move very, very quickly. But I think the framework is still good just to have in mind of like, all right, what's an appropriate starting place based on how they look right now? Where can I plug them in? And it might be a blend of these things, but I think it's good to think this way in terms of, all right, where can we start and where are we going? And what's a harder progression than where we currently are? And if it's too hard, how do I regress? So on that point, so if phase 1, the criteria to enter this one is pain-free walking, we could start some running here. So some of the examples they had in the Hickey paper that I thought were pretty good are starting running with fall runs and build up or acceleration runs. So, actually going to talk about this coming up in a course Dan and I are making. But a fall run is just, you could think of as a 10-yard dash. So I think for hamstring strain injury, this is a very, very safe place to start, because you can't reach a super fast running speed in 10 yards. So, it's that top end speed that's really placing a very high demand on the hamstring. So we could start these fall runs very, very quickly. And I might have someone do 6 to 8 repetitions of a 10-yard fall run at 50% sprint effort their first day doing this, and they're probably going to be okay. Another one that will have another type of run is a build-up run. You could think of this as something usually between 70 to 100 yards. It kind of depends on what sport they play and what you're after with the adaptation you're trying to get. But over a 20-yard distance, they might be accelerating to the prescribed effort for the day. They're holding that effort for the next 60 yards or so, and then they're decelerating at the end. And the way that we progress this over time, I kind of showed what week one would look like with that. Week one, say it's 10 yards for the fall run at 50% speed. As quickly as week 2 or 3, they might be up at 10 yards at 80% speed. And then the build-up run, if we're 100 yards, it's a 20-yard acceleration, 60-yard hold at 50% effort. By week 3, we're going to slow down or decrease the length of the top end speed, but increase the intensity. So that might be 50 yards at 80%. And I had 80% for this phase because the criteria to progress to phase 3, where we really start loading the hamstring a lot with our running, is when we get over 80% speed. So I think if we're working up to that 80% and they don't have any pain, and we're doing our testing that we talked about, especially the outer range tests, so supine 90-90 dynamometer testing, they're getting more symmetrical with that. Ideally, before progressing to phase 3, I'd like them to be close to 90% symmetry, because that's when we're really ripping high, fast running speeds. And they're making it to 80% running with no pain during running. I think the pain monitoring model is very useful for the strength training stuff. But I think once we're running at 80% intensity, I'd be cautious and really don't want to see pain during that, because that's when you're getting into, I think, risky territory with potential restrain. And we know that most restrains occur within the first 3 weeks or so. So I think that's pretty strict criteria for me, is we're tolerating the running up to 80% with no pain, and our strength is minimal to no pain during that max effort strength test. And ideally their symmetry is close to 90%. And then would progress to that kind of third and final phase.
Good stuff. Like that a lot, Kevin. A few thoughts, and I've heard this idea floating around in the strength conditioning world mostly, right? Guys like Duesh, our strength coach. It's funny how like some information is really popular in the strength conditioning world and doesn't make its way over to physical therapy or vice versa. But there's an idea that floats out there that if you have a hamstring strain injury, acceleration is a little bit more safe than top end sprinting. And it makes sense theoretically, because when you're accelerating, you're using your quads a little bit more. You're not striding out quite as much. You have kind of a negative shin angle. So you're not reaching out with your leg as much and getting that big stretch. And then when you get to that top end sprinting, now we're stretching more. We're really bringing that leg out. We have to have a lot of eccentric hamstring control when you swing that leg out, and you have to stop that leg before it has to hit the ground again. So sometimes, and I say sometimes because I think it's very variable, acceleration feels pretty good, whereas top end sprinting doesn't, right? And maybe you're able to push some of the acceleration early on. But the other thing I will say is that it's so different from person to person. Like, it's hard to even say that like the acceleration is going to go really well, but the top end sprinting is not early on, because we've seen so many hamstring injuries at Champion. And I literally just take them out the gym and I try both of them and just see what feels good and what doesn't. And it's so variable from person to person. So I think the theory kind of makes sense. Acceleration should feel good, and top end sprinting maybe doesn't feel as good, but it's very different from person to person, right? The other thing I think was really smart that you said, Kevin, because strains are a little bit interesting as an injury. I like to compare them to like a tendinopathy. So tendinopathies usually have like kind of warning signs. It's kind of like if you're squatting and it hurts like a 3 out of 10. If you increase the load 10%, now it's a 4 out of 10. And if you increase the load another 10%, it's a 5 out of 10. And it just behaves very linearly like that. Strain injuries are funny because it might be like 0, 0, 0 pain, and you keep on increasing intensity, and all of a sudden it's like, I restrained my hamstring. So you do have to be careful with that. And I've done that so many times for myself, or my own hamstring, or my calf, where I think things are going fine. I'm just kind of pushing it. And all of a sudden I'm like, crap, I just restrained this thing. So I do agree. And then even in these papers, like they did follow those pain monitoring model guidelines. But I do think that once you get towards a higher level sprinting, that's when you have to be cautious. That's when you have to like be very slow and progressive. And just because your athlete feels great, it doesn't mean that the next step they might not get hit with like a gunshot in the back of their hamstring again, which obviously stinks and you don't want to have happen, but it does happen from time to time. So you have to be a little more cautious as you progress to that.
Okay, and then getting into our third phase, again, some manual therapy as needed, I think, is appropriate. still doing a little bit of passive motion to work on lengthening and just restoring range of motion. Still using the pain monitoring model with our strength exercises. We could progress our bridge variation to an elevated single leg. We could add load to that or add speed to that. Our squat variation, I think at this point, we could be doing heavy barbell loaded squats, progressing the external load over the course of time, maybe decreasing the reps and adding more weight. Our direct hamstring work, we could be doing a prone hamstring curl with resistance. We could be adding speed to this or just adding a very heavy eccentric. We could trial some unilateral as well, just to really work that involved hamstring. The unilateral hamstring slider, we can add load by having the patient put a weight on their hip, or we can add speed. So again, we're trying to, speed is a progression for these, because high speeds are where we are really, really working the hamstring, and that's where we see the strain injuries occur. So you can progress by adding speed. The unilateral 45-degree hip extension, we can progress to adding load and speed again. And same with the single leg RDL, add load, add speed, try to work the hamstring a little bit more. And then I would still have someone doing that extender exercise daily. So that's something that we could work as well. And that's kind of from a strengthening and mobility standpoint, what phase 3 would look like.
Once people are kind of on their own program and you figured out kind of where they are in terms of like tissue irritability and what they can and can't do, then it's kind of simple, right? Adding load, adding speed, and adding range of motion. Now, Kevin did the literature review for this lesson today, so I didn't really look through all the latest research, but I do remember the last time I did this, Tim Tyler was kind of a big name that popped up, and I don't think he's done a lot of more recent research, but one of the things that he showed is that if you add range of motion to the exercise, so let's say you're doing like a seated hamstring curl exercise and you lean forward so that you're getting more of a stretch on the hamstring, or you're doing a single-legged deadlift where you're doing it from a deficit. So maybe you're standing on a box and you're trying to get the dumbbells all the way down to the floor, the barbell all the way down to the floor. So you're increasing the range of motion requirements under load. That did reduce re-injury rates in the future. So one of the things I tend to think about for like that diver exercise, you're doing a single-legged deadlift and you start adding load, you can add some more range of motion too. So sometimes what I'll have for those folks is that, yeah, we start loading them up with a single-legged deadlift, but then we actually have them do a single-legged deadlift off a box. So we're getting more range of motion. And we're doing like let's say a seated hamstring curl, I'll have them start to lean forward. So now they're getting even more of a stretch. So it's just kind of like building upon the Askling protocol. I can't say for certain like that's definitely going to make a huge difference, but some of the older research was showing that was beneficial. So I still kind of throw that stuff in the mix towards the end stage of rehab.
All right. And then this is just showing in the phase 3 how we're going to progress the running, because that's obviously a big piece for these folks, and usually often the way they got injured, and we have to progress fully through this program, I think, before returning to sport, which we'll talk about in a minute, is what return to sport criteria we want to use. But think about this. If we're progressing, the phase 2-ish is getting up to 80% intensity of 80% of a max effort sprint. Then the final phase is that chunk of 80% to 100%. So for our acceleration runs, maybe we're adding a little bit of volume, but we're progressing each session, maybe 80, 85, 90, 95, 100%. You might go a little quicker based on how the person's feeling. If you have timing gates, that might be something you could use for a little bit more objective measurements versus the subjective. It feels like 90%. It definitely gets gray there. And I think it takes a pretty experienced athlete to know the difference between 90 and 95% or 95 and 100. So, this is all theoretical. I think in the real world, it's probably a little messier than this, but I think it's still how I would progress. I think it's the best we have right now. The build-up run. So if you're thinking like 80% of your max sprint speed, you have a 30-yard build, a 50-yard hold at 80%, and then a 20-yard decrease. And then to bridge the gap from there to 100%, you give them a longer build, a 40-yard build, and then a 40-yard hold at 100%, and then a 20-yard decel. So I think as the duration or the distance of that max effort increases, the distance will decrease. So play around with the intensity versus the duration. As one goes up, the other goes down, and vice versa. So That's definitely something we got to get to in this phase is the max effort sprinting. And usually at that point, I'm feeling pretty good about getting this person back to sport.
Yeah. Good stuff. I really like your return to run protocols. Obviously, we're in the middle of making another course right now, so keep you updated when that's released. I'm pretty pumped to release it to the world. Next thing I will say, I just want to double down. I was laughing when you were saying this. I've had some athletes where they're fresh off a hamstring strain injury, and we're starting our like fall runs, and like I'll be working with like a 15-year-old, right? And I'll say, okay, let's start off your first run at 50%, right? And they fall forward, and it looks like they sprinted 100%, right? And they come back. I was like, what percentage was that? He's like, like 50. I'm like, no way, man. You just ran what looked like as fast as you possibly could, you know? So sometimes for certain athletes, you might have to slow them back or just tell them numbers that probably aren't indicative of what their like top speed is. So maybe you're like, all right, let's go 30%, right? Even though like, their 30% is more like 80%, right? So just keep in mind, like some folks are they're not going to kind of meet those RPE or percentage based, and hopefully they don't hurt themselves the first time you have them run. You're like, oh my God, this guy's going to hurt himself.
Yeah, it's always funny when maybe you partition it where you're like, let's warm up 3 or 4 reps at 60%, 70%, and then 3 or 4 reps at 80%. And they're faster on their first 2 or 3 than they're supposed to be at 80. So you're like, oh God. But yeah, it's all part of the fun of being a PT.
Good times.
So what are our return to sport considerations? I thought this was a pretty good paper from BJSM in 2017, and it's return to play criteria after hamstring muscle injury in professional football, a Delphi consensus study. So one of those Delphi consensus studies, but I think it was pretty good. We'll talk about what they recommended for return to sport.
Yeah. And just so like, if you guys haven't heard of this before, the Delphi is essentially, they just send out like surveys, the top experts in the world. They just come onto like a consensus of like, okay, we all need to strength test or we all need to do eccentrics or so on and so forth.
So their findings, this quote here is from the paper. It said 5 domains of return to play assessment were identified. The 5 were functional performance, strength, flexibility, pain, and then the player's confidence. The highest rated criteria were in the functional performance domain, with particular importance given to sprint ability. So I think as we were emphasizing in the return to running program, that's super, super important because that's usually the mechanism of injury. And that's usually something that the athlete has to get back to, especially if they're kind of a field or court sport athlete. Another thing that they said is we don't need to wait for MRI confirmed healing. This isn't a diagnosis where we necessarily have to go get an MRI to say the tissue's healed. Oftentimes, the tissue will not look normal on an MRI for a very long time. It might show changes long term, so that's not important. Don't worry about that. And then when I'm thinking about their criteria and some of the other papers that we were talking about, here's what I'm proposing for return to sport. So I definitely would like them to have shown in physical therapy that they can sprint at 100% effort in both a short acceleration run and that top end speed buildup run. I think demonstrating competency with both of those is really important. Not just a short sprint. Really, that top end speed is very important. With our muscle strength testing, they're getting greater than 90% limb symmetry, ideally closer to 100%, the better with our dynamometer testing. And this will include specifically that outer range one is very important. So supine 90-90, prone 90 degrees of knee flexion, prone 30, and then even a supine 0 degrees of hip and knee, I think could be pretty good. And then if we're looking at a muscle length performance, so the max hip flexion, active knee extension, greater than 90% of the other side. So maybe they have, 30 degrees of knee flexion on one side and 27 or 28 on the involved side. That would be a number that I think would be pretty good. So I think here we're combining the actual sporting with the sprinting, our muscle strength and our muscle length. And, if we go ahead, and I should have included in this the hamstring questionnaire for the athlete. So something that they could fill out and show confidence in their ability to play the sport. I think then you're hitting the return to sport from every angle you'd want to, and you could feel pretty confident in getting this person back. So I think that's kind of how we think about rehabbing hamstrings. And I think this criteria is something you'd want to hit for sure.
Yeah. We're also lucky over at Champion, and maybe we're going to start to bake some of this into our return to sport testing. We already do a lot of it with the ACL, but I'd be kind of curious, like some of the jump testing, some force plate testing, probably jumping, maybe counter movement jump on one leg versus the other. Potentially with the 1080 sprint, we can see how much power output they're putting on their right leg versus their left leg as they sprint out a little bit. And they probably want to see some symmetry there, but those are fancy tests that most people don't have access to. But essentially 1080 sprint can connect to a belt, can connect to like a machine via a cable, and then you can sprint, and it'll tell you how much force output you have on your left leg versus your right leg as you sprint out. So obviously not everyone has access to that, but it gives like tremendous sport specific information about how much power production you're producing left versus right, which we don't really know yet if that's going to correlate well with like handheld dynamometry strength, right? And you don't need to do the sprint, but we can do some of that testing, which if you have access to it, obviously that would be great. But we're just lucky at Champion. We get all sorts of cool tech. All right. And if you guys want to earn some CEUs, if you're a physical therapist, physical therapy assistant, or an athletic trainer, and you'd like to get some CEUs for watching this video and similar videos like this, then I'd consider subscribing to Fitness Pain Free Insiders Academy. It's $1 for a week-long trial and $25 a month afterwards. And there's a ton of great content inside of there. And if you want another video that's very relevant, that's 100% free, we have a video on how we like to do force plate testing, return to sport for athletes after injuries like ACL, but also hamstring strain. And we're going to leave that video right above Kevin's head. Go ahead and click on that, and we'll see you there.